So my name, as I said, is Grace Suva, and I am one of the managers on the implementation science team here at RNAO, and I'm going to be the moderator for today's webinar. So I'd also like to introduce you to Andrea Stubbs. She's not in picture, but she's there. And she is the project lead for the Best Practice Champions program, and she'll be behind the scenes so that she can help you with any questions that you have from a technical standpoint. So all you have to do is just type in the chat box and she'll be able to answer those questions for you. And so just to give you a bit of a caveat about these webinars, they're monthly webinars that are supporting best practice champions and those who are actively engaged in guideline implementation. And so today we have a presentation from Lori Martin on a conversation about engaging persons, families, and communities in the implementation of best practices. So just before we delve in and I introduce Lori, just a few housekeeping items to keep in mind. First off is that we do encourage your active participation. It's a way for champions to be able to share with other champions in terms of the lessons learned and experiences. So we do encourage that. And just to let you know that this webinar is going to be recorded and it will be archived and posted for future viewing on the RNAO website. And please note, because it's going to take a bit of a different format, there's going to be encouragement of dialogue throughout. So it may be that some of your chat questions or your chat comments, or if you're verbalizing and communicating directly with us, may be recorded during the presentation. So just to let you know that if you do participate, it is implied consent that you will be recorded and have agreed to do so, and that'll be posted on the RNAO website. So I'd like to introduce to you today Lori Martin, and she's a registered nurse and a Master of Public Health student at the University of Toronto. And she's currently completing a Practicum placement here at the Registered Nurses Association of Ontario. She also works as a primary care nurse at the Humber River Family Health Team and is also a BPSO OHT, or Ontario Health Team lead for her organization. And for those of you who don't know what BPSO stands for, it stands for a Best Practice Spotlight Organization. And so there are academic as well as healthcare organizations who are selected by RNAO through a request for proposal process to implement as well as evaluate RNAO BPG. So it's really quite a dynamic, supportive partnership with the focus on making a positive impact on patient care as well as evidence-based practice. And so wanted to give you that caveat before I pass it on to Lori.
All right, thank you, Grace.
You're welcome.
Get my slides up here. All right, you can see my slides okay? Great. So hi, everyone. As Grace mentioned, my name is Lori, and I am a registered nurse. I'm also a Master of Public Health student at the University of Toronto, and I've been completing a practicum placement at the RNAO over the last few months. So thank you for joining our webinar today, a conversation about engaging persons, families, communities in the implementation of best practices. Today, I'll be sharing about a project that I've been working on over the past few months, and I'm looking forward to getting your feedback based on your experiences with engagement. So our objectives for today are to help you identify where your organization is on the continuum of engagement, to discuss some common facilitators and barriers of engagement, to discuss some effective strategies for engagement, and then I'll also provide you the opportunity to give feedback related to your current or past experiences with engagement. And we'll do that through some poll and discussion questions throughout the presentation. Before I get started, I just wanted to let you know that your feedback contributions today will help strengthen this content, which may be included in the next edition of the Leading Change Toolkit. And this is a practical evidence-based toolkit for BPSO champions and change teams. So we're going to start out with a poll question just to find out who is in the audience today. So I think we'll get that poll up here. And if you could just select the healthcare setting that best represents the organization that you're joining us from today. And we'll give you a few minutes to respond to that. So it looks like we have a lot of representation from hospital, some from long-term care, academia, primary care, long-term care, and other. Maybe if you chose other, if you could just write in the chat the healthcare setting that you're from. And I think we're good to move. Oh, you know what? I'm going to share the results here, and then we'll move on.
So Lori, there is Carrie Ann from the Champlain Maternal Newborn Regional Network. You also have fellow colleagues from RNAO. Charisse is from the Mental Health Agency, and there's also CMHA, Community Mental Health, and Children Camps.
Oh, that's great. We have a wide representation, so hopefully we'll have some great discussion and feedback from all of you. So I'm going to start out with providing just a very brief overview of the project that I've been working on, and then spend the majority of the presentation on my findings, and that's where I'd really like to get some feedback. So I conducted a literature review using the research question that's here on the screen. So what are effective strategies, approaches, tools to facilitate engagement of persons, families, and communities in the context of implementing evidence-based practices in health settings? So the purpose of my project was to look to the literature to find some practical tools and resources that could be used to support change agents and change teams who are implementing best practices in health settings through engagement. And the reason that we are focusing on engagement is because the literature is showing that engagement can help improve health outcomes. And some of these include increased healthcare quality and safety, increased satisfaction with care, helping to provide cost-effective services, helping to develop trust and bring loyalty to an organization, and also facilitating collective ownership, so bringing persons, families, communities working alongside staff in efforts to improve healthcare or health services. So for my literature review, I searched 4 different databases, Embase, CINAHL, Medline, and Cochrane, over the last 10 years, limited to the English language. And we were looking for peer-reviewed literature that focused on a strategy, tool, or approach for engagement that had a population of either person, family, or community engagement with healthcare providers or staff in any health setting, and had an outcome that focused on effective engagement in the context of implementing best practices in a health setting. And we excluded anything that did not meet our inclusion criteria, as well as any articles that took place outside of the health setting. We also excluded any focus on engagement within a research context, as well as within the context of individual level of care. So for example, shared decision-making or individual involvement in care, that was not within the scope of the research question, as well as excluding a focus on guideline development, as our focus was really on implementation. So one of the articles that I came across in my review was by Carmen and colleagues, and they describe this patient and family engagement framework, which is on the screen here. And it's developed by the American Institutes for Research. And so this framework describes engagement across a continuum, which is at the top of the framework, as well as at different levels of engagement on the left-hand side of the framework. And this framework was referenced in a few other of the articles that I came across in my review, and it also found that it was recognized by the Canadian Healthcare System with the Canadian Patient Safety Institute, as well as Health Quality Ontario. And so I decided to use this framework to guide the summary of my findings, mainly using the continuum of engagement to provide examples of engagement, and then describing or suggesting strategies at the 2 highest levels of engagement, so organizational design and policy making, given the context of my research question. And so that brings me to the summary of my findings, which I've categorized into 3 themes. So the first is the continuum of engagement, barriers and facilitators, and engagement strategies. And this is where I will focus the remainder of my presentation on. So I'm going to start out with explaining the continuum of engagement, And as I go through the continuum, I would just encourage you to think about where your organization fits along the continuum. So the continuum moves from left to right. So on the lower end, we have consultation. And this is where persons, families, communities participate to some degree within the organization, but they have limited power or authority to make decisions. So for example, you may ask them to share feedback from time to time, or ask them to provide input into your safety and quality committees if you have those, but they aren't formally represented on committees. As we move up to involvement, this is where persons, families, communities share some responsibility in making decisions and setting priorities. So for example, actively participating on safety and quality committees and being representatives on advisory councils. And then at the highest end of the continuum, there's partnership and shared leadership. This is where persons, families, communities share power and responsibility, and they become active partners in making decisions and identifying priorities. So for example, at this level, you would have equal representation on leadership boards and having persons, families, communities act as partners or co-leads for a safety and quality committee. And then the continuum can also be used to guide the process for planning for engagement, as well as assessing current engagement practices. So it's helpful, as I mentioned at the beginning, to first identify where you are on the continuum. And you can do that by identifying practices that may or may not support engagement within your organization. And then based on where you are on the continuum, you can use an assessment to help identify priorities for either improving, strengthening, or sustaining engagement. So I have just a few examples here on the screen across the continuum. So if you're at the consultation level and just sort of starting out your engagement practices, you want to ask persons, families, communities, and staff about their perceptions of engagement to help identify priorities so you can develop an action plan to help improve engagement within your organization. At the involvement level, you're likely already implementing some sort of engagement practices. So here you would want to ask persons, families, communities, and staff about their experiences of the current engagement practices and to see if those align with organizational priorities and identify priorities to strengthen engagement. And then at the higher level, partnership and shared leadership, here's where you want to periodically ask persons, families, communities, and staff about their perceptions and experiences of engagement so that you can reassess and prioritize areas to sustain engagement. So that's just a brief overview of the continuum. I want to pause here for another poll question and just asking you to rate how clear your understanding is of the continuum. So if you're still not really clear, you can rate it as a 1. If you're pretty clear, rate it as a 4 or 5. And if you're somewhere in between, you can rate it as a 3. So it looks like most people are ranging between 3 and 5. And 2 people rated at a 2. We'll just stop that there. So I'm just going to pause here. If there are any questions or comments for clarification, either related to the continuum of engagement or anything that I have previously gone through. Oh, and I will leave that at pause.
So if you have any questions so far or any comments, please feel free to type in the chat box. And if you do, to send it to all panelists and attendees so that we can see your comments or questions. Otherwise, if you're good to go and to proceed with the rest of the presentation, just maybe give me a smiley face or a thumbs up or whatever it may be. Okay. Okay, so there are some comments here. There's one comment on, I have an understanding of the continuum, a lot to cover in a short amount of time. Yes, it is. And it just takes a bit of time to process and absorb. Thanks for sharing your presentation. Smiley face, this is clear, I like it. So a lot of thumbs up and smiley faces, Lori.
Okay, great. I think we'll move on then. So now that I've gone through the continuum of engagement, I'm going to move on to talking about some barriers and facilitators of engagement. And I've summarized these into 3 different categories. So into selection and recruitment, communication and logistics, and organizational support. And how I've presented these are a barrier and then a facilitator that could be used to address the barrier within each of the categories. And you can keep, if you have any like questions or comments related to these barriers, you can just save that until I've gone through all of them, and then I will pause for a discussion question at that time. So I'll start out with barriers and facilitators for selection and recruitment. So one barrier might be disproportionate involvement. So for example, involving more staff than either persons, families, or communities. And so a facilitator to address that would be recruiting a higher proportion of persons, families, communities than staff. And in the literature, it was recommending to aim for at least 1/3 representation. Another barrier may be biased recruitment. So not selecting people who are representative of the population of interest. And a facilitator to address that would be aiming for wide representation and recruiting through a variety of networks that target the population of interest. And then another barrier in this section is recruiting persons, families, communities who cannot effectively communicate and contribute. So a facilitator to address this would be selecting people, keeping certain characteristics and skills in mind. So for example, that they have an interest in the topic, that they're comfortable speaking in a group, that they have the ability to effectively communicate their personal experiences, and also that they're able to listen to and hear differing opinions. And then for communication and logistics, one barrier may be role disagreement. So a facilitator to address this would be clearly defining and formalizing the roles and responsibilities for everyone involved. Another barrier may be limited opportunities outside of meetings to interact and build trust. So a facilitator for this would be providing opportunities for regular interactions, including both formal meetings as well as informally, whether that's emailing or texting between meetings, and also allowing time for trust to develop. Another barrier that has come up was fears of intimidation. And so some facilitators to address this are making sure you have an onboarding or orientation process, and other ideas offering joint training, so bringing together staff with persons, families, communities, and collectively doing training, and also providing opportunities for feedback. So just ensuring that after meetings or whatever you're doing, that you have some time to debrief. And then a few more here for communication and logistics. Another barrier is the overuse of jargon. And so a facilitator to address this would be preparing staff to intentionally avoid the use of jargon when interacting with persons, families, and communities. Another barrier is reduced motivation or commitment over time. And some facilitators to address this would be making sure you regularly track and also share progress, whether that's monthly or quarterly or annually, depending on what your organization decides. Consider offering incentives or reimbursements if needed. So for example, for time, for childcare, for travel, etc. And also making sure you schedule meetings at times that are convenient, as well as locations that are convenient, and maybe consider rotating that, as well as considering having a term membership so that you can continually bring on new people, bringing new ideas and new motivation. And then the last category here, organizational support. So some barriers may be lack of organizational guidance. And so a facilitator to address this would be ensuring that you have leadership support before initiating engagement, to involve staff who have leverage to affect change within your organization, and also to consider making person, family, community engagement an organizational value that's recognized by everyone. Another barrier may be competing priorities, whether that's related to policies, procedures, or pressures from senior management. And so a facilitator to address this would be, when possible, choosing recommendations from persons, families, communities that align with the organizational goals and strategic plan. And then the last two here. So another barrier is a lack of organizational response and follow-up. So to address this, you want to make sure you have access to leadership support who can follow up on issues that are raised and also facilitate bringing ideas into action. Another barrier is fears of exposing organizational shortcomings. So to address this, you can ask all members to sign a confidentiality agreement. And then a final barrier here is hierarchy. So for example, having a staff-driven agenda. And a facilitator to address this would be strengthening and facilitating person, family, community input by creating opportunities for open sharing and feedback, and also creating opportunities for them to set or co-create agendas. So I know that was a lot of information to take in, and I do want to pause here for a discussion question. And just wondering, based on your experiences, if there are any barriers and facilitators that are missing. And you can post that in the chat or raise your hand.
Okay, excellent, Lori. While you're thinking about Lori's question, there are a few comments in the chat box. There's one comment: I like the idea of fulsome onboarding for patients and ensuring better proportion of patients on committees. Also, it is true that we have to reduce the use of jargon. We also have another comment: joint training is a great recommendation as well, provides opportunity to build rapport to enrich future conversations. And there is also another comment: I love how you have simplified the barriers to language that is understandable. So kudos to you, Lori. And there's a comment: how do you incorporate cultural barriers?
I mean, that's a good comment. I mean, one way would be making sure that you have different representation from different cultures within whoever you're engaging at the table, whether it's through a meeting or through a committee. I don't know if anyone else on the webinar has experience of addressing this barrier.
Yeah, it's an excellent question. If anyone else has any an experience or examples of this, that would be fantastic. There is one comment: our program, CMNRP, has a family advisory committee with many members with young children. So we have invited children to attend, and also an online option, and that was pre-COVID. Oh, excellent.
Mm-hmm.
Yeah. And if there are any other comments about the list that Lori had outlined in terms of any other barriers or facilitators that may be missing, and any other additional commentary in regard to the cultural barrier, which is a really good question.
So I just actually have a question for Carrie Ann. What is the CMNRP program?
Children's something. Yeah. Oh,
great.
Champlain Maternal Newborn Regional Program. There you go. Thank you, Carrie.
All right, so if there aren't any more questions or comments, I'll move on. All right, so I'll move on to talking about some engagement strategies. And the engagement strategies that came out of the literature, I sort of came out into 5 areas or themes. So the first was collecting and sharing feedback. And the second was advisory council. The third was committee and project teams. The fourth was health system strengthening. And then the fifth was experience-based co-design. And so I'm going to focus on the first 2 strategies today: collecting and sharing feedback and advisory council. So I'm going to go through each of those separately, and then I do have some discussion questions related to each. So I'll start out with collecting and sharing feedback. And so the literature was recommending sort of 2 different methods for collecting feedback. So the first is through voluntary feedback. So providing opportunities for persons, families, communities to voluntarily share their care experiences or feedback or input to the organization. And so an example may be having anonymous suggestion or comment boxes that are available. The second method is solicited feedback. So this is where you're actively asking persons, families, communities about their care experiences or to provide their input into program or policy or service improvements or changes. So some examples to collect solicited feedback would be having satisfaction surveys regarding to care, facilitating discussion groups, or conducting individual interviews. And then when you collect feedback, it's equally important to share feedback. You want to create opportunities for persons, families, communities to share stories and experiences with staff, organizational leaders, other patients, as well as the general public. And so some examples of this are creating opportunities to publicly share personal stories, whether through radio, through social media, or other means, as well as creating opportunities within the organization. So opportunities to share stories at new employee orientation or at staff training, or if your organization has team huddles or at board meetings, to reach a broad spectrum of people within the organization. Those are the collecting and sharing feedback strategies. And I'll pause for another question here. So wondering if you recommend any other strategies that you've used for collecting and sharing feedback.
And of course, collecting and sharing feedback, I mean, as champions, it can take on various contexts as well. When it comes to implementation of practice changes, you know, from the board to the bedside, how has sharing and collecting feedback been utilized at your workplace?
Or if you've used the examples that were provided.
Mm-hmm. Well, one individual says triangulation. So definitely have a representative, you know, feedback and be able to triangulate and collect information in different ways. So I'm assuming, Juanita, it could be through one-on-one conversations, or it could be through surveys, or it could be town halls or focus groups. Take on any, you know, maybe telephone interviews. So yeah. Is there any other examples or any other strategies? I know that there are out there. Carrie Ann is saying we typically ask for feedback during meetings, and lately we have sent documents through Google Docs and focus groups as well. And Juanita, just expanding on what she said earlier, one-on-one and then as a group with the same individuals. So sometimes there's that different dynamic when you have the one-on-one and then as a group. Christina saying, I think online methods can be useful for sharing feedback. So for example, online surveys, because participants can remain anonymous and it could be very user-friendly. And there's also a comment about using SurveyMonkey. Terry says our hospital also uses SurveyMonkey to collect parent feedback. Information is shared through huddles and feedback is posted for the staff to review. And specific comments about nurses is shared with that nurse. We also have another comment, feedback from patients when they get discharged. So I've also heard that when it came to, you know, an experience with discharge planning and calling families afterwards, after discharge, to see how, you know, how well they were satisfied with the services. And then David says we use telephone and one-to-one methods. So it seems here there's a lot of variety of ways that individuals are using ways to be able to collect that information, and then most importantly also to be able to share that information in a meaningful way and to be able to act on it. Susan is saying it's also important when you collect feedback to share this back with people to ensure that you've understood correctly. Okay, yes. So for example, if you do do a focus group, then you check back and confirm with people and check if you missed anything or misinterpreted comments. So that's a really a good point, because you want to make sure that you're representing the patient family voice accurately and as they have conveyed it to you. So I agree with the validation process as well. So any other comments in terms of strategies, or if you're a BPSO and have implemented PFCC or the Person Family Centered Care Guideline, perhaps, if you have any strategies in terms of collecting and sharing feedback from patients or families. There's a lot of great comments here though, Larry.
Mm-hmm.
Was there anything else you wanted to perhaps piggyback in terms of this question?
I don't think so. I just wanted to mention that I liked from the comments from Terry that when you're collecting feedback, you're also posting the feedback for staff to review, because I think that's really important that when you're collecting feedback, it's going somewhere, it's being shared.
Mm-hmm. And there is a comment in relation to your discussion on facilitators and barriers, and the one specifically about the cultural barriers. Kara is saying, I have received feedback in past contexts that certain meeting formats, for example, agendas, sitting uninterrupted around a table, are quite Eurocentric and hence not accessible across cultures. So sharing food and integrating personal discussions are examples that have been shared with me. So definitely, yeah, I agree as well. Some, you know, if there's more of a storytelling format, there's just some ways of sharing. So again, being cognizant and perhaps also getting feedback in terms of the best ways of being able to collect and share the feedback and be able to share as well. Charisse has also mentioned that, so there's a lot of use of SurveyMonkey, and obviously also the, another comment saying the use of client-friendly language. So again, going back to your facilitators and barriers and being mindful of those facilitators and barriers when you're collecting and sharing feedback, so that it is received and interpreted correctly and acted on appropriately. So there you go.
All right, well, thank you, everyone. I'll move on here to talking about advisory councils. So another strategy is having an advisory council, which is a group of patients and or family members or caregivers, depending on the organization, who regularly meet with staff members and organizational leaders who are dedicated to improving the quality, the safety, and experience of care. So we're going to put up another poll question here. Just curious to know if your organization currently has a patient and or family advisory council. You can respond to that. So it looks like a lot of people do. Let's look one up. Okay, so about 75% have said yes, which is great, because I would really like to get some feedback based on your experiences with your advisory councils. Move on here. Okay, so in the literature, I came across some best practices that are recommended for advisory councils, and I've adapted these from Hatley et al. And Sharma et al. And they're categorized into the areas of recruitment, logistics, the meeting process, and implementation and follow-up. So I'm going to go over these best practices. There is a little bit of overlap with some of the facilitators and barriers, and then we'll have some discussion at the end based on your experiences. So some best practices that are recommended for recruitment is to have a formal interview process, to recruit members who have strong communication skills, and to recruit members who are reflective of the patient population, to provide support and training for new members, and to consider having ongoing recruitment with rotating term membership. You can bring new perspectives and new voices. And then recommendations for the logistics are having a group of size of around 7 to 15 people. And again, that would vary depending on the size of the organization. Having monthly meetings, formalizing a terms of reference, and this helps guide the focus and infrastructure of the group. Consider offering reimbursement or incentives as needed, and to involve staff who are dedicated and also have the required time and resources to commit to being involved, and also to assess leadership readiness for engagement. And then some best practices for the meeting process are to have a strong and trained facilitator to help guide the meeting, to encourage patients to share their personal experiences, and that may require sometimes directly asking about their opinions or their experiences. Another idea is to invite staff members from the organization to come and share their role as members so that everyone has a better understanding of the roles and what's going on within the organization. And also to facilitate opportunities for members to reach out to the patient population to hear what their needs are. So for example, one idea was having an informal coffee hour where you bring patients and family members and staff together to discuss ideas to improve care. And then some best practices for implementation and follow-up is, again, you want to clearly define patient and staff roles. You want to choose projects that are feasible to be implemented, and also to start with small tests of change that can result in seeing an improved experience for both patients and the organization. And then also to establish clear methods of communication between the advisory council and the rest of the organization to make sure that their voice is being heard. All right, so I just have a few more discussion questions here. So first is if you disagree with any of these best practices. And then second, based on your experiences, if there's anything else that you have found works well when engaging with advisory councils. And you can post that in the chat.
Okay, excellent. Really good questions. While you think about that and reflect on that, Susan is saying, I'm wondering if people have struggled to find patient and family members who are representative of the patient population. And if that particular population is disadvantaged and marginalized, they might not have much confidence in speaking up. Any good tips for this? Do you want me to read it out again, Laurie?
Yeah, sorry, I lost my chat.
That's okay.
I have it up here now. Okay.
Okay.
So I'm wondering if people have struggled to find patient and family members who are representative of the patient population. Yeah, I think that's a good point, Susan, because I think oftentimes when you're recruiting people to be involved with an advisory council, people who volunteer or want to be involved are more actively, I guess, represented within the organization. And so really just taking that time to reach out to people and to recruit them. And again, going to where your population is at.
And if there's anyone else who can answer that question as well, I'm sure there's a lot of experience online. And again, I'll read it out. In terms of people, have anyone else have struggled and have any strategies to find patient family members who are representative of the patient population? And if that particular population is disadvantaged and marginalized, they may not have much confidence in speaking up. So if anyone else has any tips, that would be fantastic. So in opening that to the larger group, Sharice is saying we conduct family groups for specific programs, as well as having speakers corner for clients. Joanne is saying a suggestion would be to work with the groups within that population, like community champions. It's an excellent idea. And Kathy is saying at SE Health Transition Program, we continuously engage the patient advisor to join staff training, media events, hospital program meetings. So a consistent patient representation and engagement across many programs in SE Health.
I just have a follow-up question for Joanne. If you just have any examples of engaging community champions or recruiting a community champion.
And Joanne is saying, for example, I worked with people living with dementia. I worked with groups facilitators who invited me to attend their group and introduced me so I could explain what I was looking for. Oh, so that, yeah, that's excellent. That's excellent. So going into and experiencing and asking the groups and going in and be engaging with the groups. Yeah. And Susan is saying, I love the idea of having representation at staff training. Jackie is saying, we do onboarding of our client and family advisors. We provide public speaking training. Ah, okay. And like others, clients and families can attend staff training as well. That's amazing.
I love that idea of providing the training.
Yeah, that's really good. Those are excellent ideas. Okay. And yeah, Carrie Ann agrees, great idea. David is saying, to answer Susan's question, I work with acquired brain injury population, ABI. We use a buddy system for new patients. Former patients buddy with new patients that might be interested in being involved in engaging in an organization. Very often patients would like to be involved but feel inadequate after a brain injury. Having a buddy mentor role model helps them. I love that idea. That's really good. Sort of the having a mentor and someone who is been oriented and is comfortable and sort of like that peer-to-peer, sense of safety, that you understand where, I'm coming from as well. And this is how I've been able to actively engage in the organization. I love it. Another comment, it's important to present to the community that experience and variance of persons is valued. That is balancing the perception and the educators, that the educators can know and offer more. And Joanne, yes. And Joanne is saying, if you can afford it, usually offering food attracts people. Kathy has said, we also conduct 8-week care conferences with clients, families, and RH staff when applicable. At that point, we invite potential patient advisors to join the committee. Amazing. Peer support workers and specialists as a staff helps too. Susan is asking, do they pay their advisors? So I think there were a couple comments there about advisors, but if you can perhaps answer that question, that would be fantastic. And
or if there's incentives provided.
Yeah, or incentives, yes. And Joanne is also saying, we also asked our staff to identify clients' patients whom they felt would be a good champion and ask their permission to give their name to be involved in advisory groups. Yeah, so tapping into the network that patients and families are within that necessarily we wouldn't be tapped into. So sort of the gatekeeper snowballing effect. And Jackie is also saying, I work with people living with mental health and addiction challenges. Many people live in ODSP, fixed income, and could be considered marginalized. Best advice is not to judge or discriminate, make space available for them. Yeah. So creating that platform for a voice, I think is really important. And Joanna is saying, we found several great dementia champions this way. That's amazing. And Kathy is saying, not that I'm aware of in terms of incentives or any payment or anything like that when it comes to advisors.
I'm also curious, a follow-up question here is, how long do people usually stay on your advisory council in terms of a term, a long-term membership?
And diversifying the representation, and also it's a lot of work. Yeah, different perspectives. So Jackie is saying, we provide food at meetings for clients' families where appropriate. They are not financially compensated, but there is policy in the works to start compensating. Yeah, those are really great comments. And Kathy's also saying the transition program is less than 2 years old. Our advisor has been a member throughout the whole program. So definitely trailblazing in that role, in that program. So I'm sure there's lots of words of wisdom to share there in terms of experience and how to continue to grow patient representation and provide a platform for that. And Susan is saying it would be interesting to know what makes people want to stay in the roles. So what are these incentives? What drives people to want to participate? And in the meantime, Jackie is saying our councils also have a budget resources office. Our council members can rotate through the general membership for 3 years and then on to executive for 2 or 3 more years. And our clients and families stay because they see tangible changes. Yeah, that makes sense, that they're making a difference and their voice is being heard and there's action taken. Yeah, we don't ask them to rubber stamp. That's what Jackie's saying. Yeah.
Yeah, I think it is important that you want to involve people long enough that they can see a change or see that they're able to make a change within the organization.
Mm-hmm. And I'm just curious how patients' families are acknowledged or celebrated for their contributions. Carrie Ann says, I agree, seeing their feedback and action is extremely important and can be rewarding as well. So, I mean, being able to see progress is very motivating. And Joanna's saying, I had members on one of my advisory groups staying on for so long that I found it morphed into a support group. And eventually I had to form a new group as I found we kept hearing the same comments. So there you go. I mean, it's turned into something else and you're serving another important purpose. So, hey. And then having the foresight to, you know, provide them and continue to provide that safe space, as I think someone else was saying.
I think that's great.
Yeah. And another comment, we've been having weekly meetings during COVID and we have had a very similar experience. So that's reinforcing. And an advisor recently said, a vote is better than a voice. Making clients' families part of decision-making makes them stay. Yeah, so feeling empowered. And exactly, they remained friends. And Juliet is saying our client and family advisors are registered volunteers. They receive some benefits as volunteers, such as waived parking costs, beverages, increased access to office space, and email address. Okay, yeah, those are actually really great ideas. It makes it easier to be able to function in the role, just those little logistics and yeah, excellent comments. Thank you so much, everyone, for sharing. And Laura, did you want to expand on any other your questions, or do you have questions for some of the audience members?
I don't have any specific questions. I just want to thank you so much for this really valuable feedback. It's great to see that when you're looking at something within the literature that it's also being played out in practice and tangibly. So that's exciting to see. I'll just roll over here if there's any last minute sort of questions, comments, just in general, not necessarily related to just the advisory council.
Excellent. And please feel free to share anything that you want to share before we wrap up. I think it's been an excellent presentation, Lori, and lots of engagement and comments and really meaningful feedback and food for thought that Lori can bring back for her work. So, and thank you very much, Lori, for all your great work with RNAO and to help to us to be able to learn how to better engage patient families and communities in the work that we do. And Susan is helpful, saying that it's been very helpful. David says, are we seeing a PDF of the presentation? So they definitely want your presentation, Lori. The registrants will receive a PDF copy of the presentation. And Lori has graciously agreed to share her email address as well, so that if you have any other questions that you would like to ask her, she is open to that. And again, everyone is saying, Lori, a lot of people thank you for your work in this very important area, and for the comments and the dialogue and for sharing. And so I think that is going to come to a close. So thank you very much, everyone, for your awesome contributions. And just to let you know, Andrea will be sending you an evaluation in regard to this. So please feel free to to fill that out. It's for Lori and for us to be able to continue to learn and to, in regard to how to better serve you as champions and in this network. And again, if you have any comments or questions, please feel to email also Andrea Stubbs at astubbs@rnao.ca. Otherwise, you can email Lori directly in regard to your questions to her presentation. So thank you very much, everyone, and have a great afternoon.
Thank you.
Thank you.